Good morning to all the participants. Today we are at the fourth day of our AICT Atal FTP on artificial intelligence in healthcare. So today we are having with us Professor Rangaraj Sir, Rangaraj M. Rangayan. So Sir is currently Professor Emeritus in Electrical and Computer Engineering, University of Calgary, Canada. And Sir previously worked in various research and academic and administrative positions in the University of Manitoba, Canada, and University of Calgary from 1981 to 2016. Sir's qualifications are PhD in Electrical Engineering from ISC Bangalore, Karnataka in 1980. Sir's research interests lie in digital signal and image processing, biomedical signal and image analysis, and computer-aided diagnosis. Sir's notable achievements are Sir have published more than 170 papers, journal papers, and 270 papers in proceedings of conferences. And according to Google Scholar, Sir's publications have been attracting more than 16,000 citations with a H index of 62 and item index of 236. Sir has been recognized with the 1997 and 2001 Research Excellence Award of the Department of Electrical and Computer Engineering in the 1997 Research Award for the Faculty of Engineering appointment as University Professor 2003 to 2013 at the University of Calgary, and Outstanding Teaching Performance Award in School of Engineering 2016. Sir research have been features in many newsletter, magazines, and newspapers as well as in several radio and television interviews. Sir has been invited to present lecture in more than 20 countries and has visiting honorary professorship with different universities of countries like Romania, USA, Brazil, India, China, Japan, Italy, France, etc. So we are very much happy that Sir have acknowledged and agreed to give a talk for our FTP, and it is really a privilege to have you here, Sir. And I know, Sir, since we were in MTech, because I started learning biomedical signal processing from your book only. So that from that time I know you, and I was very much fortunate to meet you on 2012 when you visited IIT Guwahati. So I am very much happy that, and actually this is, I could say, it is a achievement for my life that you agreed and came to our workshop. Welcome you, sir. Welcome from the Department of ECE and Guwahati University. And without any further delay, I give you the platform so that you can start, sir. Thank you, sir.
Thank you. Well, I would like to start by wishing all the participants a very good morning and all the best in your studies and research. I would like to thank Dr. Mehdi for inviting me to participate in this workshop, this series of lectures. It's a very timely and important topic of current interest: the applications of computers and engineering in healthcare. It's my pleasure to present to you an overview of our research work over several years, spanning biomedical signal analysis and medical image analysis for computer-aided diagnosis. So I would like to call this seminar Computer-Aided Diagnosis Engineering Improved Healthcare. As mentioned in the introduction, I'm Professor Emeritus of Electrical and Computer Engineering at the University of Calgary in Canada. Much of this work was done here at the University of Calgary. Some of my initial work was done when I was doing my PhD at IISc in Bangalore, where I worked with Professor ISN Murthy towards my PhD on biomedical signal processing, working on signals such as the ECG heart sounds, EMG, and so on. After moving to Canada, most of my research projects have been on medical image processing, although we have worked on a few signal processing projects also. As Dr. Mehdi mentioned, I have authored a book on biomedical signal analysis, of which we are now preparing the 3rd edition. And I have another book on biomedical image analysis published by CRC Press, and another on color image processing published by SPIE. So these books hopefully will be useful in your studies and research. Computer-aided diagnosis is referred to as CAD, C-A-D. But CAD has different meanings in different contexts. So what is CAD? The dictionary definition of CAD as a word is an ill-bred man, especially who behaves in a dishonorable or irresponsible way toward women. Now, that's not a good person with good behavior, and that's not what we're going to talk about today. Coming from Canada, CAD is also, CAD is also the Canadian dollar. And previously, CAD has been used to mean computer-aided design, drafting, and a few other things. In the medical imaging context, CAD is also used to mean computer-aided detection and computer-aided diagnosis. There is a distinction between computer-aided detection and diagnosis in the sense CAD for detection is simply to say there is something at this point here in this image to mark a region of an image or a part of a signal as something that deserves to be examined in more detail by the physician. The computer program does not give any interpretation, but simply marks or points to an area. Whereas computer-aided diagnosis goes a little further and says, well, in this part of the image, there is something suspicious, and most likely it is this particular disorder caused by this particular disease. So diagnosis goes one step further in suggesting a potential diagnosis. But we should note right away that we are talking about computer-aided analysis of biomedical signals and images by physicians, by medical experts. So it is computer-aided or assisted and not automated. It is not robotic analysis or automated analysis by a computer giving the result directly to the patient. Instead, the results of application of computational procedures are given to the medical specialist, a physician, cardiologist, radiologist, neuroscientist, whosoever is working with that particular problem. So what are we talking about here? The application of computational procedures, including a few different areas, subject areas, digital signal processing, digital image processing, and pattern classification or pattern recognition methods for various purposes, starting with enhancement to enhance biomedical images and signals, segment and characterize regions of interest, to identify normal patterns and structures, and to detect abnormal features and diseases for computer-aided diagnosis or CAD. These are some of the techniques we use and some of the applications, and I'll illustrate these over the next 2 hours. So here are some examples of signals that we record from the human body. From the heart, the most common signal, ECG, electrocardiogram. From the brain, brain waves or EEG, electroencephalogram, in multiple channels. I have shown 3 channels, but it is common to get dozens of channels, sometimes 200, 300 channels simultaneously from the scalp. We have also worked on knee joint vibration signals from the knee joint as the patient is swinging the leg to get vibration signals that could possibly be useful in the diagnosis of arthritis and other joint problems. Moving to images, we have the traditional chest X-ray image, In the case of women, we have mammograms, images of the breast. These are two-dimensional projection images where the three-dimensional body is integrated along the direction of propagation of the X-rays through the body, and we get a shadow image, a projection image. The 3D body is compressed to 2D. Using computed tomography, you can get cross-sectional images using X-ray computed tomography. Here is an example of a cross-sectional image of the brain. Using magnetic resonance imaging, we can obtain various slices. This is a sagittal slice of the knee joint, showing the various parts of the knee joint. Using ultrasonography, you can get images of various parts of the body, in this case, of a fetus in the mother's womb. Using nuclear medicine imaging in single photon emission computed tomography, you can get images of various parts of the body, kidneys, liver, thyroid. In this case, sectional images of the left ventricle of the heart. This is the left ventricle of the heart, which is useful in the detection of blockages in blood supply to various parts of the heart due to ischemia, or also to detect infarction. So these are some examples of signals and images that are commonly used in diagnostic applications. There are many, many more signals. And more signals are being discovered, or signal processing techniques are being developed to acquire more and more types of signals and images from the human body to investigate the human body, functions of various systems within the human body, and to diagnose various problems that could potentially affect these systems. To start with a simple illustration as to what we could do and what needs to be done quite often, let's look at the ECG here. This ECG signal, you can easily see the beats 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 beats. There's no problem in just counting the number of beats, but if you want to analyze the waveform carefully, you see that there is some artifact, this black patch. If you zoom in, you see some additional waveforms and variations about the baseline and around the waves in the ECG. Now, that is high frequency noise. And you also see that the baseline of the ECG is going up and down and up and down. And that is low frequency baseline drift. So there is high frequency noise artifact. Excuse me. There is low frequency baseline variation. And this could also include power line interference. Excuse me. Power line interference in India at 50 hertz or in Canada at 60 hertz. And not only the fundamental, but also harmonics of the power line frequency. After applying a low pass filter, we get this image, the signal rather, where this black patch that you see here, which is high frequency noise, has been removed. So you have to choose an appropriate bandwidth. In the case of, in this third example here, third trace, we have the result of high pass filtering. And the baseline variation that you see going up and down, that has been removed. The baseline is now constant. There is still some artifact here, which you can't see unless you zoom in, and that is due to power line artifact. And by applying a comb filter, the power line artifact, fundamental frequency, and also the harmonics that are present in this signal as artifacts have been removed. And finally, you get this clean signal. So this is a kind of enhancement of the signal. You are improving the quality of the signal, and the filtered signal without now all these artifacts hopefully contains the clean ECG signal that can be interpreted and analyzed more efficiently by a cardiologist. There is no analysis or interpretation by the computer at this stage. Unfortunately, what happens quite often is when you remove some noise components, some desirable components of the signal may also get canceled or deleted. And there could be some distortion introduced. So the wave shape here is slightly different if you pay very close attention and zoom in. And by the way, you can download a PDF file of this from my website. And if you zoom in, you will see that the wave shape here has changed. The T wave, and after the T wave, this wave, the signal shape has been modified slightly. That is because of the high pass filter that has been used. So unfortunately, when we remove artifacts, we might be introducing some distortion too, and we have to be careful about that. Sometimes it might be unavoidable. After removing artifacts, it is quite common to go to the next stage of detecting parts of the signal or segmentation. You break the signal into parts. Here, we want to identify the QRS complex, the sharp wave, which is related to contraction of the ventricles. This is the P wave due to contraction of the atria, the upper chambers of the heart. And this is the QRS and the T wave, and that is due to contraction of the ventricles, the lower chambers of the heart. To do that, there are various algorithms based on taking the derivative of the signal and squaring and filtering. And these diamond points, marks here, and the circle marks indicate delimitation of the QRS complex, detecting the QRS complex and marking the beginning and end automatically. This was done in a MATLAB program that I wrote, a very simple program, but it can be done using many, many different methods now. Some of these methods were part of my PhD thesis, which was completed in 1980, some 40 years ago. Now, of course, that kind of work will not give you a PhD anymore. You have to do a lot more hard work. What you see also here is that we have normal beats, the first 3 beats, and then this beat that is very different, what is called a premature ventricular contraction, caused by not the sinoatrial node, which is the natural pacemaker of the heart, but some other pacemaking part of the heart which is abnormal, known as an ectopic focus. So the wave shape is very different, typically broader and slower wave shape. So in this case, we have been able to cut all these parts for every beat, identify the approximate beginning and end of each beat. And the interval between the beats has been computed, 660 milliseconds, 650 milliseconds, and for PVC, 570 milliseconds. It is premature. So the interval between this and the previous beat is shorter than what is the normal case. And then the wave shape needs to be analyzed too. Since the wave shape is slower and broader, the variance of the signal is different between PVC and normal. There's a technique called, or there's a measure called form factor, which takes the variance of the derivatives of the signal and takes ratios. And this number increases for PVCs 3.11, 2.83, compared to normal 1.5. So this is just one measure. In practice, when you want to develop an application, you typically will compute many more measures. But using just one measure, we are able to classify these beats. So here I have the ECG of a patient having a number of PVCs marked as X. All the beats marked as O are normal. There is a training set, which I'm not showing. And based on the training set, thresholds were developed for form factor and the RR interval between beats. And these beats were classified automatically, but this was done offline in a MATLAB program. And all these beats marked O are normal, and all these beats marked as X are abnormal, PVCs, except for one false positive. One normal beat was misclassified. If you only have 1 or 2 errors like this over several hundred beats, it is acceptable. But if there are many such errors, the confidence of the physician or the specialist in using such a method will be diminished. And in practice, you would not do such analysis using just 1 or 2 features. You would compute many attributes of features so that if one measure fails, hopefully a different measure will catch the error and you get better classification result. So this is a very simple example using ECG, that patterns that can be clearly seen and everybody knows what ECGs look like. So what I have illustrated are the basic steps of removing artifacts, which could be called enhancement, segmentation or detection of parts of the signal, that is, cutting each beat, the ventricular contraction part of the signal for each beat, and then computing features or attributes to characterize the signal so that we get different numbers or different values for different types of patterns, and then making a decision, classification. That could potentially help in diagnosis. In monitoring critically ill patients in a cardiac intensive care unit, it is important to monitor the patient's heart rate and also keep count of the number of ectopic beats that the patient may have. If the patient has a large number of ectopic beats, then some intervention may be desirable. Now let's go to images. In the case of images, there are some similar steps that might be desirable. Here is one slice of a 3D computed tomography data set, excuse me, of a pediatric patient. I'm showing only one slice, but it's a 3D data set. This is one slice through the abdomen. You see the pelvic bone, the spine, and some internal organs here, kidney and liver and so on. This is the examination bench, or the table on which the patient is lying, through which takes the patient through the scanner. The data that we get from the scanner could have many extraneous elements, blankets and IV tubes and many other things outside the patient of the body. In order to analyze the CT data set of the patient's body, we need to remove all these artifacts outside the body. So starting from the outside boundary of the image, we remove all these artifacts by growing a region until we reach the skin surface. In computed tomography images based on X-rays, the tissue properties of the human body for various types of tissues have been tabulated in medical papers and books. So we know the Hounsfield unit range, the X-ray attenuation coefficient range for various types of tissues, for skin, for liver, kidney, bone, and so on. They're all tabulated. So using this prior knowledge, we can identify the outer surface of the patient's body, that is the skin surface, and remove everything outside that. So this is the part of the image. So this is a kind of enhancement or segmentation. We're removing artifacts outside the body. And then we grow the pixels or voxels, volume elements of the skin layer by thresholding and region growing. We get all the volume elements in the data set that have the Hounsfield unit range for the skin, and they should all be connected. And we remove that. So this is peeling the data from outside in a computer program automatically. And after skin, going inside to the body, there is peripheral fat. Fat has Hounsfield unit values that are negative because fat has density that is less than that of water. So that is very easy to identify by region growing and thresholding. So this white area is peripheral fat between the skin and the muscle. Remove that. And then we expect to be at the layer of peripheral muscle. And again, the Hounsfield unit range for that is known. Grow a region in 3D. All of this is done in 3D. And remove that. And now we are at the level of the internal organs, the bones, the liver, kidney, and the spinal cord, and so on. Spinal canal, the whole spine is there. So this is, in a way, what is called landmarking. We are identifying different structures. All these structures are normal structures. And we're removing them. If you need to analyze them, you may do some analysis, but perhaps there is not much interesting in these parts. What we want to do is examine the abdomen, examine the thorax, examine the pelvis of the patient, and look for any abnormalities such as tumors. We can render the data in 3D. After removing the peripheral artifacts, this is the skin surface of the patient. The data set is from just below the neck to the level of the pelvis here. That's the data set we have in this case. After removing the skin layer, this is peripheral muscle, peripheral fat. And after removing peripheral fat and peripheral muscle, we're at the level of the internal organs. But this is just displaying the surface. That doesn't help much. In this study, we were interested in detecting and analyzing tumors due to neuroblastoma. Neuroblastoma is a childhood disease, a pediatric disease that affects that some newborn babies could have. And if a newborn baby has neuroblastoma, then the patient must be followed up carefully by X-ray imaging, and treatment must be provided, chemotherapy or radiotherapy. And then the tumor has to be shrunk. And if the tumor responds well to treatment and is completely neutralized, then nothing may be done. But if surgical removal is necessary, surgery could be done after the tumor has been brought to a manageable size. In some cases, the patient's situation may improve naturally, and the tumor may go away by itself. The disease may clear by itself. If not, this treatment is important. In order to detect such structures, tumors, and structures of the body that might be affected by the tumor, it is necessary to identify other normal structures to know where we are and where the tumor is with respect to important structures in the body. And one of the important structures is the spinal canal. If the patient is to be provided radiation therapy, it is important to irradiate only the tumor and not sensitive parts of the body, such as the spinal canal, which is here in the spine. So when beams of radiation are sent through the patient, they should be designed such that the tumor that needs to be destroyed gets most of the dose, and other parts of the body do not get much. The other parts of the body do get some radiation, but that should be kept at a minimum. And passing the radiation beams through sensitive organs such as the spinal canal must be avoided. To do that, the radiotherapist should know where the spinal canal is in the patient, and for that, the CT image may be used, but that needs to be identified and demarcated too. So to identify the spinal canal, we did segmentation. We removed all the outside artifacts, as I mentioned, and we know that the spinal canal is within the spine, and the spine has heavy, dense bone. So we segment the bony structures in the body. And we know the patient is lying on the back, and we know where the spine should be approximately in this part of the image. And we go to that part and identify the bony structure based upon the Hounsfield units. And in the abdominal and pelvic areas, upper pelvic areas, the spinal canal is almost circular in shape. As you move further up through the chest, the shape changes, and when you come to the neck, the spinal canal shape is almost triangular. And as you go down to the pelvis, the shape changes too. So we select slices of the CT image through the abdomen in the middle of we know where the CT images have been taken, which part of the body. So we choose the abdominal section, identify the vertebral column, and get the edges by applying edge detectors such as Sobel and various edge detectors, essentially taking the derivatives of the image, of the binarized vertebral column part of the image. Now we have a circular shape here. To detect circles, there's a technique known as the Hough transform. Using the equation of the circle and parameters that are limited according to the size of the body and the size of the vertebral column and the spinal canal, ranges are known for these parameters. We select the best fitting circle to this part. Now there are many circles like this edge, like that part of the image. It's not a full circle, but it's like a 3/4 of a circle. This is about half a circle. So when we apply the Hough transform, it finds many circles, potential circles. Many of them are not complete circles, and even this circle is not guaranteed to be complete. So we need to find the correct circle. And for that, we ask the question, for every circle that we can identify in the given range of size, what is contained inside the circle in the original image? In the original image, we want the spinal canal, and the Hounsfield unit values for the spinal canal are known, they're tabulated. If not, we can find it from the data set available to us. Whereas other circles will have parts of the vertebral column or vertebra. The vertebral column and the vertebra, they are higher density bones, so their Hounsfield unit values are much higher than the Hounsfield unit values for the actual spinal canal. So now we ask the question, which circle do we take? The circle within which there are Hounsfield unit values that are in the range of that for the spinal canal. And we mark that circle. This is done automatically, of course. We mark the center and do that for all the slices in which we expect a circular cross section. Then, using the center, we select a few pixels from each slice, a small number of pixels around the center. So this is not the actual shape of the vertebral of the spinal canal. It's not a circle. So we take a few pixels from the center and grow a region in 3D. And using the statistics of the pixels we have detected, we know the Hounsfield unit values and standard deviation, their mean and standard deviation. So we can grow a region in 3D and we can get the spinal canal in 3D. I'll show that to you in a couple of minutes. Then the next organ of interest is the diaphragm. The diaphragm is at the bottom of the lungs and separates the thoracic cavity from the abdominal cavity. To detect the diaphragm, we first detect the lungs. Detection of the lungs is fairly easy because lungs are filled with air and lungs have very low density tissues. And this part will be the largest part in the body with the lowest Hounsfield units, lowest density, lowest X-ray attenuation coefficient. There could be other parts of the body with some air, stomach and other parts. There could be small chambers filled with air, but the lungs will be the largest air-filled cavity in the body. And it is easy to detect and segment them based on this property and the Hounsfield unit range. Then we go to the sections in the CT image below the lungs towards the abdomen, and we identify these structures. The diaphragm in some slices may appear to be one large muscle spanning almost a complete section, or in some sections could be cut into two parts, or maybe just one part. So again, we know the approximate position as to where we are in searching below the lungs. We know the Hounsfield unit range for the diaphragm, and we know it has to be connected to the bottom of the lungs. So we do region growing using these constraints and obtain these regions as the diaphragm in various sections of the CT image. Here, the red lines, red contours are those drawn independently by the radiologist, and the green contours are the contours detected by our method for each slice. Sometimes it's not very accurate. Sometimes it is, the results are good. We have compared the segmentation using our methods with the hand-drawn contours given by the radiologist for reference, and computed distance measures and overlap measures to show the performance of the method. I won't go into those details today. I'll show you the result here in 3D. Here we see the lungs of the patient, these transparent purple colored regions in 3D, and the initial segmentation of the diaphragm, various slices showing the diaphragm. There could be some noise and artifacts in the segmentation of the diaphragm in this manner. So we applied linear least squares fitting and active contour modeling, and the yellow region here is the diaphragm after filtering. The diaphragm is like a dome under the lungs, but it is not just one parabolic dome. It has some variations, and that's what you see here. So now we have the lungs, we have all the bony structures, high density bone structures, calcified structures. We have the diaphragm, we have the spinal canal. Next, we wanted to find the pelvic girdle. So we go further down in the image. In the pelvis, we have really hard bone. Even in children, these bones are well developed and have high density. So we search for high density structures and do region growing and get the pelvic girdle, which are these high density regions in the image. And again, the contours drawn by the radiologists are shown in red, and those obtained by our methods are shown in green. And we have published papers with quantitative assessment of the results, which I won't go through today. Next, we wanted to look for the neuroblastic tumor. The tumor, depending on the stage of the cancer and the result of treatment, response of the tumor to therapy, the tumor could have very widely varying density composition. In this case, you see these white regions within the tumor. The red contour is the contour drawn by the radiologist, and lighter density here and some darker low density regions. So the tumor is composed of calcified tissue, which could be due to therapy, radiation or chemotherapy, parts of the tumor that have responded to the treatment or due to natural response of the body, and the tumor has, the tumor tissue has been killed and calcified. So the density has increased. Or there are parts that are of low density. If it is very low density, it could be fat. If it is of low density, it could be scar tissue. If it is of intermediate tissue, intermediate density, it could be other parts of the abdomen mixed in, liver tissue or kidney tissue. If it is higher than abdominal tissue, it could be active tumor. So this tumor structure, which could be a ball that big, could contain a mixture of different types of tissues, and segmentation was quite a challenge. So we had to ask the radiologist to assist to provide an initial seed region in one slice. And then we did 3D region growing using opening by reconstruction, a morphological filtering technique. We also did segmentation by fuzzy region growing and a few other methods, and obtained the tumor in 3D. But we could not automatically detect the tumor, and we could not do automatic segmentation. We needed a part of the tumor to be identified by the radiologist on one slice, and then we could do the rest in 3D. So here is a 3D rendition. Lungs and everything above the diaphragm, the upper contour of this orange region. Everything above that is the thoracic cavity. Lungs and whatever else, the bones you have there, that is thoracic. And below that is the abdomen, the region in orange. Below that is the region that is the pelvis. The boundary between the thorax and the abdomen is the diaphragm, which is this, which was automatically detected. The boundary between the abdominal region and the pelvic region is the pelvic girdle, which is this bony structure that was automatically detected. The vertebral column was automatically detected, this transparent structure, and inside that, the spinal canal was automatically segmented, the sort of reddish region here. So all of this was done automatically in computer programs with some guidance only for the tumor detection and segmentation. The tumor is shown here. So this is, and you also see the ribs and other bony structures that were detected and segmented automatically. So now you can say that this is a kind of enhancement of the image. Unwanted artifacts have been removed. It is landmarking because some structures, skin and peripheral fat and so on that were not interested were identified and removed. And those that are remaining have been labeled as lungs and the region of the abdomen, the region of the pelvis, and the region of the thorax, and the ribs and diaphragm and vertebral column and the hip bone and so on. So this is also landmarking. Many of these structures are normal structures, but we also have identified the abnormal structure of interest, which is the tumor. Next, we wanted to analyze the tumor. What is the composition of the tumor? So here we have 3 images of a patient, the same patient, taken in April, June, and September of a particular year. At the time of initial diagnosis, the tumor is very large. This is the liver of the patient, the kidney. The internal organs have been displaced and pushed around by the tumor, which is large. The tumor has some calcified tissue, the bright part here. It has some fatty tissue, low density tissue here, and intermediate tissue compared with the liver here. Anything that is brighter than this, but not as bright as bone, this very bright white area, will be active or viable tumor. This is the tumor after 2 months of treatment. The tumor has become smaller, approximately in the same section. The tumor is smaller, and there are more white regions, bright white, which is calcified region. That is, the active tumor part of the tumor has been killed, destroyed by treatment, and it is calcified. It is covered by calcium, and it has become higher density. And 3 months later, there's more calcification. This is the desired response of the tumor to treatment. We would like to see the active tumor being destroyed and the tumor becoming smaller in size and becoming higher density calcified tissue. How do you quantify it now? To analyze the relative proportion of these tissues, we used Gaussian mixture modeling. We obtained the histogram of the 3-dimensional tumor after segmentation from multiple slices of the CT image of the patient. And that is shown in this solid line here. And that was subjected to Gaussian mixture modeling to identify 3 components. And the 3 Gaussians are shown here. 1, low density. This is in Hounsfield units. 0 is water. Negative Hounsfield unit will be, will be fat. Negative is fat and then air. As you go higher, up to about 60, 70 Hounsfield unit values could be abdominal tissue. A little higher than that, 80, 90 could be active tumor. Beyond that, 200, 300 will be calcified tissue. 400, 500 will be solid bone. So we have 3 components which are Gaussians here. If you add up these 3 Gaussians with the weight shown there, you get the total histogram of the tumor. So now we know that there are three components. Two components are in the range of the abdominal organs and tumor. This one is spread a little towards higher density, so this could be calcified tissue. After treatment, 2 months later, the histogram is broader. There are more voxels towards higher density, higher Hounsfield units. And we get one of the Gaussian mixture model components here with a peak around 90. So that is abdominal tissue and tumor tissue. And the second Gaussian has a peak at 200, and the third one around more than 300. So these two are calcified tissues. And the first one is likely a combination of normal tissues and cancer, viable tumor tissue. After 3 more months of treatment, the histogram is much broader, more pixels or voxels towards higher Hounsfield unit, going up to 900 in the tumor. And the first component is still having a peak around 100, but the second and third at 200 and 400. So these are clearly calcified tissues. And the first one is a combination of normal and tumor. The relative proportion is what is of interest. In the initial image, the components had mean values of 64, 94, 134. 64, 94, two components are in the range of normal tissue and tumor. Only one component, which is also having a smaller weight, is of calcified tissue. After treatment for 2 months, the first component has become smaller, the second component is bigger and higher density, higher Hounsfield unit, 175. The third component, 323, harder, more calcification. After 3 more months of treatment, the first component has become even smaller, and the second and third components are bigger, calcified tissue. So what this shows is the expected and desired treatment, desired response to treatment. So this is analysis of the response to treatment of the tumor. We see that the tumor volume has reduced from 500 centimeter cube down to less than 100. So the volume has reduced, which is good, and the components have shifted towards higher density, which is what you can see, of course, from here to there, but this is in one slice. There are multiple slices. We took the 3D data into account. Visual analysis, one could do based on 1 or 2 slices, but if there are many slices, it becomes difficult to guess such statistics. And this is accurate statistical analysis of not only the tissue composition of the tumor, but also the response of the tumor to treatment. So this was our work with a pediatric radiologist at the Children's Hospital in Calgary to assist in the analysis and treatment of neuroblastoma. Next, let us move to a different part of the body and a different clinical problem of retinopathy of prematurity. Retinopathy, meaning diseases of the retina, the detector we have at the back of the eye. Retinopathy could be caused by diabetes in the case of adults, and in the case of very premature babies also, due to the incomplete development of the retina, and that is due to very early birth at 23, 24 weeks of gestation, like just 6 months of gestation. Such babies have very low birth weight, and the retina is not fully developed, and there is a high probability of such premature babies having retinopathy of prematurity, or ROP. And if it is not diagnosed and treated immediately, there is a danger of the child going blind for the rest of the life of the person. So this is a very serious issue in the case of very premature babies. There is a stage of ROP called plus disease, which is the stage where ROP is advancing. That is, the disease is deteriorating, the retina is deteriorating at a high rate. And that needs to be detected. So here are some examples of images taken using a video camera. The camera has to make contact with the eye. Unfortunately, it's a difficult procedure because the very premature babies are in neonatal intensive care units in oxygen chambers. And to take this camera and take images by making contact of the lens with the eye is not an easy task and very uncomfortable for the babies too. In any case, images like this are taken. These are images from premature babies, no ROP. These are the main blood vessels. This is the optic nerve head or optic disc through which blood vessels come into the eye from the brain and go back to the brain. And the optic nerve goes to the brain from the back of the retina. This is stage 1 of ROP. Stage 2, stage 3. What I would like you to notice or observe are that as the stage increases, as the disease gets worse, the blood vessels become thicker compared to this, compared to that. These vessels are thicker. There is dilation. And the major temporal arcade, the angle of insertion of these blood vessels into the optic disc, this angle becomes smaller, narrower. This parabola is wide. This is also wide. Here it is wide. This is narrow. This is narrow. And blood vessels become winding and tortuous instead of being fairly smooth curves or almost straight lines. Here you see high curvature, what is called tortuosity. So the objectives of our research project in CAD of ROP were the following. First, you must detect the vessels and measure the thickness of the major temporal arcade. The ophthalmologist would observe that there is dilation of the vessels. Vessels are broader or thicker, and we want to measure the width. But where do you measure the width? Vessels are thick here, and as you go away farther from the optic nerve head, they become naturally thinner and thinner. Vessels are thick here, and then they become thin, and they turn into capillaries and disappear. So where do you measure thickness? How can you say there is dilation? If you measure thickness here, it'll be very small. If you measure here, it'll be thick. So we need to define which part of the vessels are you measuring. So we said we will measure only the major temporal arcade. The temporal arcade is this, towards the macula. And in these images, it's very difficult to see the macula or the fovea in premature babies. And then we want to quantify the openness of the MTA, the major temporal arcade, by assuming that it is a parabola, and also by measuring what is called the temporal arcade angle, the angle of this, or the curvature of this parabola, approximate parabola. And it is a parabola only up to this point. After that, the shape changes. It is not a parabola far from the optic nerve head. Only close to the optic nerve head, it is like a parabola. After that, the blood vessels converge and come down, they bend downwards and then merge into something else. And then quantification of tortuosity. So these are the three tasks that we took up. First, we must detect the blood vessels. So here is an image from the DRIVE database. This is of adults. The DRIVE database has images of adults, but anyway, we designed Gabor filters. Gabor filters are orientation sensitive detectors. They are made up of wavelets that are Gaussians modulated with sinusoids. And we can detect blood vessels. at all angles. We can threshold this and get a binary map. By using Gabor filters, we can not only detect blood vessels, we can also get their orientation angle at every pixel. At every pixel in the image, if there is an oriented structure, we get the angle of that structure. And we also wanted to detect the optic nerve head or optic disc. We use the Hough transform to detect circles and fit a circle to the optic disc. But the optic disc is not always a circle, and that method fails. So instead, we use the orientation field obtained from the Gabor filters and found the point of convergence or intersection of the blood vessels. All the blood vessels go into the optic nerve head or come out from the optic nerve head. So that's the point detected using our method, which is a point within the optic nerve head. And then if you want, you can grow a region around it and detect the bright region and find the boundary. This is landmarking. Now we are detecting all the blood vessels, we're getting their angles, we are detecting the optic nerve head. This is the macula, but we did not work on that. There are methods in the literature to detect the macula also. To measure the width, we designed an elaborate procedure. So here is an image of a pediatric case converted to an intensity or brightness image, Gabor output. Finding the optic nerve head, we cut the image into the superior part, which is the upper part, and the inferior part, which is this. And we cut a part of the image from the optic nerve head towards the macula with a distance that is less than half of that distance between the optic nerve head and the macula. Or we take a distance that is proportional to the width of the optic nerve head, which is tabulated. And we take only this much of the image, this part, from the optic nerve head towards the macula. So we analyze this strip of the image, in the upper part and in the lower part. These blood vessels that were detected using the Gabor filters are binarized and filtered. All these extra artifacts are removed by morphological filtering. And we get the skeleton. The thickness is removed and only a 1 pixel thick line is produced along the major blood vessels, which are the parts of the major temporal arcade. We use the canny edge operator, which gives all these other edges, many spurious edges. But we want to get the edge of the major temporal arcade using the skeleton as a reference. The edges that are on both sides, on either side of the skeleton, are detected, and we get the vessel. And to the detected center, to the detected skeleton line, we draw perpendicular lines. We know the direction from the Gabor filter angle. We draw perpendicular lines until these lines cross the edge given by the canny filter on the two sides. This is for the upper part, this is for the lower part. This is all done automatically. And whenever there is an intersection or branching point of a vessel, we do not measure the thickness because there is no defined thickness there. Now we are measuring the thickness of the major temporal arcade only from the optic nerve head up to a certain distance that is related to the width of the optic nerve head. Only for this width. The upper part, the lower part. So we have so many measurements. Dozens, maybe 100, maybe 200 measurements. And of these, we take statistics, mean standard deviation. So in this case, the width is 111 plus minus 18 micrometers. In the case of a patient with plus disease, you can see that this is thin, this is thick with the same scale of the images, same procedure, and the thickness is 125 micrometers plus minus 17 standard deviation for this much only. So now we have a thickness measurement of a specific blood vessel, the major temporal arcade, in a specific region from the optic nerve head, approximately up to the macula. And if there is dilation in that region, we can give a measurement of that. So this is measurement of the width and to detect dilation of the blood vessels. And we showed that this is a good predictor of ROP by using a database that was annotated by an ophthalmologist. The ophthalmologist also told us that the shape of the major temporal arcade changes due to the disease. There is pulling of the major blood vessels when scar tissue is formed, and that changes the shape of the blood vessels. So blood vessels that are having a broad parabolic shape will have a narrower parabolic shape due to ROP. So we said, well, it is approximately parabolic. Well, let's try fitting a parabola. So here we have the major temporal arcade, the superior part and the inferior part. The image is rotated a bit. This is the retinal race, the line joining the optic disc and the macula. It is not horizontal. In this case, one parabolic model will not fit the blood vessel, the major temporal arcade, well. It is fitting well for the upper part, but not the lower part. The blood vessel is here, the parabola is there. So we said, let us break the image into two parts, the upper part and the lower part, and fit parabola separately to the upper part and lower part, and take only the upper and lower parts of the parabola. Now we have two parabolas, half parabolas. The upper half parabola, the lower half parabola. Now each parabolic model fits the contour of the major temporal arcade very well. And note that the parabolic shape is applicable only from the optic disc up to the macula, and after that the blood vessels change shape. So the parabolic model is not good beyond the macula. So we are using only the part of the MTA, the major temporal arcade, up to the macula from the optic nerve head. When you fit a parabola, we have a number. Now we can put a number on the shape. In this case, no plus disease. The parabola y equal to ax, the value of the parabola parameter a is 78. When we did separately for the upper and superior and inferior part, we get 72 and 78. If you measure the temporal arcade angle, there is a procedure given by researchers in England. It's a manual procedure. One has to mark the center of the optic nerve head and draw a circle of a specific radius and mark the points where the circle cuts the major temporal arcade, join those 3 points and measure the angle. Now we wrote a computer program to do that and got the temporal arcade angle, in this case 156 degrees. But depending on the size of the circle drawn, you get different angles. So they're recommended 2 different sizes of the circle, 156 or 140 degrees, whichever you like. In the case of a patient with plus disease, the angle is lower. The MTA, the parabolic model A value is also low, 10. Angle is about 80 degrees. Here, the angle is 140 degrees and parabola model is 72, 78. So now we have numerical representation of the shape of the major temporal arcade. And again, we analyzed a database of patients with and without plus disease and showed that this was also a good predictor of ROP and plus disease in particular. In the case of diabetic retinopathy also, we showed that at a late stage called proliferative diabetic retinopathy, there is a similar narrowing of the temporal arcade, major temporal arcade, and the parameters for normal are 153, whereas for PDR, 55. So there is a clear narrowing of the shape of the major temporal arcade. The last part of the work on retinopathy of prematurity was to measure the tortuosity of vessels and identify tortuous vessels. There are various definitions of tortuosity. There's no single definition, but there are different algorithms proposed to estimate tortuosity or to get some numerical representation of tortuosity. Unfortunately, the methods available in the literature at the time we did this work were not clearly identifying which vessels were tortuous and were not giving a length of the tortuous vessels, but instead giving some numbers that were hard to interpret. If you simply give a number for tortuosity and say this image has tortuosity of 25 or 32, that doesn't mean much. So we said, well, we should measure the tortuosity, and tortuosity means the vessel angle is changing. So having identified all the blood vessels, we tracked each blood vessel, going pixel to pixel along each blood vessel and getting the angle of the Gabor filter corresponding to that output. So at every pixel of every blood vessel, we know the angle phi p. And we track every blood vessel, so we know that we are moving along a blood vessel pixel to pixel. If P is the current pixel along a blood vessel, P minus 1 is the previous pixel, and P plus 1 is the next pixel along that blood vessel in its skeleton. So it is not a 3 by 3 neighborhood or a 5 by 5 neighborhood, but connected pixels along the skeleton of the blood vessel. And we ask, what is the angle given by the Gabor filter? Phi p minus phi p minus 1. If the blood vessel is almost straight, the angle difference between the two pixels should be almost 0. Blood vessels are not straight, they curve slowly, so the difference should be small. Similarly, phi p minus phi p plus 1. Compare each pixel in its angle to the previous pixel and the next pixel along the blood vessel, and take the sine of that. The sine of a very small angle is very small, almost 0. And since you're taking 2 of those, take half of that. If there is a large difference between these successive angles, then the value increases. This is for 1 pixel. Now for all of the pixels along a blood vessel segment, so we break the blood vessels into segments. I'll show you how to do that. We add up and average these values and get an average angle variation index, and we call that average tortuosity for that vessel segment. And this number is between 0 and 1. It is good to have normalized measures that are between 0 and 1 or plus minus 1. So they are easy to interpret and compare. So here is an image with no plus disease. This is a zoomed part of a blood vessel. And along the blood vessel, we are showing these lines given by the Gabor filters to show the angle. And we track each blood vessel. So this is the Gabor magnitude response. This is the thresholded result. This is after binarization. We identify straight line segments, part of these of the skeleton where there is not much angular variation. And we remove those pieces. And we also remove points where vessels are branching or vessels are intersecting. And we get this result. So these are segments of the blood vessels that are not straight. And for each of these segments, we compute the measure that I described just now. Notice that these are short segments. And all of these segments were determined to have the threshold, to the tortuosity measure below a threshold that was determined using a training data set of images. So everything is marked as green just for display. This is a case with plus disease. You see many tortuous vessels. Zoomed. These blue lines show the angle estimated by the Gabor filter, and the angle is tracking the blood vessels accurately. The Gabor magnitude response for the full image, all the blood vessels detected by thresholding, straight line segments identified and removed, So these are segments that are not straight. And of those that are marked in red are tortuous, determined by applying a threshold to the measure of tortuosity. So here are two more images. No ROP, very few, two small pieces of vessels that were considered to be tortuous. They're not really very tortuous. The threshold perhaps was too low. This is the case with plus disease and many segments that are tortuous. So now we have identified segments that are tortuous and segments that are not tortuous. And next, the question was, how do we convert this into a number that is useful to the ophthalmologist? Giving this measure of tortuosity the sign of some angle difference, that doesn't make any sense to a medical specialist. Instead, we said, well, we can measure the length of these blood vessels that are tortuous. So we can say so many millimeters of blood vessels are tortuous in this image, and we can show in display that these are the blood vessels that are tortuous. And the image is broken into 4 segments with the optic disc in the middle. And segment 1, segment 2, or quadrant 1, 2, 3, 4. In each quadrant, we measure the length of the tortuous vessels. And then we developed a rule. If the total length of all the tortuous blood vessels in the image is greater than some threshold, or if in any one quadrant, the total length of tortuous vessels is more than some limit, then this patient has plus disease. So that was a rule we developed based on a training data set, and we got very high accuracy with that. Much better than the results we got with vessel thickness or the shape of the major temporal arcade. So we were told by the ophthalmologist that the 3 criteria to detect and diagnose ROP and stages of ROP are dilation or thickness of the vessels, and in particular the major temporal arcade, the shape of the major temporal arcade, and tortuosity. And for each one of them, we developed these techniques to quantify them, and showed by analysis using receiver operating characteristics and various pattern classification and decision-making techniques that these techniques can give accurate diagnostic decision. The third set of examples I would like to give you in medical image processing is in the area of mammography for breast cancer detection. There are various signs of breast cancer that can be seen on mammograms, which are X-ray images of the breast. The breast is compressed, X-rays are passed through the breast, and previously a film was used. Nowadays, a digital detector is used, and an image is obtained. One of the signs of breast disease, including cancer, is the deposition of calcium in the breast, known as calcification, these bright spots. It is important to detect these bright spots even when they are very small, known as microcalcifications, to analyze them in terms of how many of them are present in a square centimeter or some given area and position, and the shape of the individual calcifications and their spatial distribution in the mammogram, to come up with a diagnostic interpretation as to what these calcifications mean. In some cases, it could be due to benign breast disease, some disease that is not cancer, and other cases could be cancer. This case, it is abnormal because there is a large cluster, many calcifications in one cluster, and it is heterogeneous, different density and different shape. To detect calcifications, we developed many techniques. Calcium is of higher density than breast tissue, normal breast tissue, so it should be fairly easy to apply a threshold and detect them. But unfortunately, when breast tissue is compressed and projected, superposition of normal breast tissues could lead to density that is comparable to low density calcification. So we developed a technique based on linear prediction. Linear prediction in one-dimensional signals is commonly used in speech signal processing and modeling of various biomedical signals. The idea is that you use a certain set of the available data to predict the next value. You compute a linear prediction model, an autoregressive model, using a certain number of pixels or a certain number of data samples and predict the next value using the mathematical model. If the signal has good behavior and is following the computed model from the same signal values, then the prediction will be good and the error will be small. But if you are using a small part of the image here to predict the next pixel, in a uniform area like this, the prediction will be good. But when you come to a calcification like this pixel, the prediction fails. Using the preceding pixels that are here, it is not possible to predict that value, which is very different. Similarly here, you can predict this value from the previous values and the next and the next and the next. But when you come here, you cannot predict. The model fails. And that is indicated by a high prediction error. Of course, you know the value of this pixel from the image. So you compare the predicted value with the actual value. And if it is more, if the difference is more than some limit, you say, oh, there is an error, and we mark it with a black point. So these pixels that are marked as black are pixels where the model failed. And that is where we expect calcifications, as you can see. Wherever we have calcifications, we have these failure points of the model. This was done in 2 dimensions, 2-dimensional linear prediction modeling. And from these points, we grow regions by accumulating pixels that are similar and put some constraints. Calcifications cannot be that big. So there is a limit on the size and some density characteristics. These are the detected calcifications. We compared with manually annotated results given by the radiologist and showed that this method performed well. When you have the contour, you can also detect, you can also analyze the shape. When you have thresholded, when you have grown regions for the individual calcifications, we can classify them as being normal or cancer and so on. Not normal, but benign disease or cancer. So to do this, first you must detect points that are within calcification, then grow regions, then get shape factors, and then classify. Next, another sign of breast cancer is a tumor or a mass. A mass in the breast is a high density nodule or region, which appears as a high density or brightness region in the mammogram. So this is a suspicious region in the mammogram. This is low density fatty tissue, and you come here, there is high density. Some of these high density, there are other regions also of high density, but these are not tumors. So that's a problem. Due to superposition and integration of the breast tissues in a mammogram, you could get other bright regions also. We developed a method to identify contours of isointensity, brightness, isobrightness, in the mammogram at various stages of filtering, multi-stage, multi-scale filtering using Gaussian filters. And we get contours like this that are similar to contours of elevation in an altitude map, topographic map. So when there is a high density region, we expect many contours or families of contours, one inside another. And when there are such families of contours, we find the biggest contour including all of them, and that we expect to contain a tumor. Unfortunately, this leads to several false positives, all these red regions. The red region shown here is the contour obtained by our method. The blue contour is that drawn by the radiologist. We didn't get all of the spicules, but we got some of the shape complexity in the segmented region. Once you get the contour, here is the contour given by the radiologist. we can perform shape analysis. We can break the contour into parts that are convex, curving outside, concave, curving inward. By detecting points of inflection where the curvature of the contour changes, and at every point of inflection, we break the contour. There is a convex part, the red part, and a concave part, a green part. In the case of a benign mass, the shape is round or oval, and there is no concavity, there is no indentation. So there should be no concavity at all in the case of a benign mass. In the case of a malignant tumor, there'll be many spicules. And when there are spicules that are finger-like protrusions, whenever there is a protrusion, there is a convex part, and there must be a concave part next to it. Then another convex and concave. So convex and concave parts will alternate in this manner in the case of complex contours due to breast cancer. First, we should also analyze the false positives and get rid of false positives. For that, here is an example of an image where this is the tumor, the small part, and we were able to accurately detect and get the contour of that tumor, but we got one false positive here. And there were other false positives at the initial stage, but by analyzing the orientation, we were able to reject false positives, which were mainly along fibroglandular tissue of high density like these that are almost straight. By analyzing the orientation of the texture along such false positives, which in most cases were straight, we were able to reject most of them, except this one in this case. So we obtained detection accuracy more than 80% with about 4 false positives per image at that time. After detection, we want to extract features. We want to characterize the tumor regions or mass regions. So here is an example of a mass region, the contour drawn by the radiologist. And by breaking the contour into parts, we have the white line indicating convex, black line indicating concave part. So not much is concave. So we measure fractional concavity. We add up all the concave parts and divide by the total perimeter and give a number that says so much of the total contour is concave. And then we dilate the ribbon, this boundary, and get a ribbon around the tumor, a little inside the tumor or mass and a little outside. So this gives the context of the boundary. We are removing a certain core part of the mass and getting not only a region inside the mass, but also outside, using the boundary and by enlarging or dilating the boundary. And using texture measures in this region, we showed that the texture in the ribbon around the tumor or mass can help better in classifying benign versus malignant tumors as compared to taking the entire region inside the contour, which is what was being done previously. And then by drawing perpendiculars to the contour at every pixel, we're getting the normals to the contour, and we compare the density outside with the density inside along each normal and get measures of contrast. A benign mass has high contrast, whereas a malignant tumor has very poor contrast. The boundaries are fuzzy, and the tumor is heterogeneous. So by combining measures of shape, texture, and sharpness of the edge, we are able to distinguish between benign masses and malignant tumors due to breast cancer. For example, this is a benign mass with a clearly defined outline or boundary, what is called well circumscribed, and benign, it is homogeneous inside, sharp boundary. No concavity, it's completely convex. Acutance indicating sharpness is 0.07, fairly sharp boundary, and a texture measure using Harrelix methods. This is a macrolobulated benign mass, fairly homogeneous, but the boundary is not completely convex. There are some concavities, but not much. This is a malignant tumor, microlobulated, very small, fine indentations. And this is highly speculated. These two are malignant due to breast cancer. The numbers are different. Fractional concavity has increased to 0.6, 0.8. Acutance has dropped from 0.07 to 0.01. So by using these numbers, some of these features that we have proposed, we are able to distinguish between benign breast masses and malignant tumors. Then we can do pattern classification, and we have shown that we are able to perform classification between the two types of breast masses with high accuracy. For example, using a combination of shape factors, the combined number for benign masses, all these contours that are smooth are benign, marked as B in this data set, except this one that is malignant. If you put a threshold of 1.31, all these would be classified as benign, but 1, 2, 3 of them would be wrong. Unfortunately, these malignant tumors have smooth contours for some reason. And all of these are malignant with combined shape factor more than 1.31. Now, instead of making a diagnostic decision using these features or attributes, you could also do content-based retrieval. Suppose a radiologist who is new to the work encounters this case and does not know what it is. It looks clearly benign, round shape, high contrast, fairly homogeneous inside. But suppose the radiologist doesn't know that. The radiologist could send this image to the program, which will compute the features that I described, and compare the features, the attributes computed, with all the features of the images available in the data set for which the diagnosis is available and the patient records are available, and bring 3 or 5 or 7 or how many ever that the radiologist wants, cases that are similar to this, not in visual appearance, not in terms of patient's attributes, but in terms of attributes, the quantitative measures, these numbers of the shape and texture and sharpness of the tumors. And then here are the top 3 retrieved from our database, the contours and the grayscale images of the part of the image with the tumor or mass. And all these cases in the database, they say these are benign. So the radiologist can say, well, all three of the nearest matches are benign, so this is also benign, which is true, this is benign, so it works. And here is a case that is malignant, and these are the retrieved examples closest to this in the database. Now, our database is not very small, very big at that time. So these were what were pulled out. All of them are malignant. So one could clearly say with confidence that this is malignant, which is true given the speculated shape and heterogeneous appearance and poor definition of edges. But note that these are not identical. This contour is not the same as that. They're not similar in appearance, but they are similar in the attributes, in the complexity. They're similar in the attributes that are computed. So in that sense, from quantitative analysis, they are judged to be similar. And these are malignant, all 3 are malignant, so one can say that this is also malignant. So content-based image retrieval using such techniques, using essentially the same features as one would use for pattern classification, will help in retrieving cases with known diagnosis and established images with established features, and then help in decision making. The radiologist or the medical specialist makes the decision in this case, not a computer program. The last sign of breast cancer that we worked on is called architectural distortion, where there is no tumor, no calcification, nothing is visible, but just some distortion. It's very difficult to define. But we tried to work on it and kept on asking questions to our colleague from radiology. And he gave us some clues as to what architectural distortion looks like. The first thing we were told is, well, the tissue structure is distorted. Well, that's what the name says. But what does it mean? In a normal mammogram, the breast structures you see should all converge towards the nipple. And that is the structure of the breast. The milk-producing glands, ducts, and supporting ligaments, they all connect to the nipple. That's where the milk comes out from. So the structure has a converging appearance towards the nipple. And that is seen in a mammogram too. So the oriented texture of the mammogram should point towards the nipple. If you have structures pointing to other directions, then there is something wrong. If you have structures that are intersecting at multiple orientations, that is also suspicious. So based on that, we used Gabor filters to detect oriented structures, all these oriented tissues. At every pixel, we get the orientation angle. These lines give the angle. And you can see in this place where architectural distortion has been marked in the database, there are many intersecting structures oriented at different angles. So we used the node map that is obtained using phase portrait analysis of these angles, and we get a high response. This is like a node intersecting angles. But there are many other high response points. There are intersecting angles here too, you can see. This is the pectoral muscle, and there are some intersecting structures, so there is a high response. So there are many false positives. So to overcome false positives, we had to design more measures. And then we asked the question, can we go to earlier mammograms taken before cancer was detected, and is there architectural distortion in what is called prior mammogram of interval cancer? Interval cancer is defined as a situation where in a screening program where women come every 2 years, let's say, to get mammograms taken, if a woman is coming every 2 years, let's say 2020, 2018, 2020, the next visit is 2022, but in 2021, the woman has something suspicious and gets a mammogram and cancer is detected somewhere. In the screening program, there are images taken 1 year, 2 years, 4 years before. And then we can go back and check those images as to what was there. Why was nothing detected? So these images are called prior mammograms, prior to the detection of cancer. And Dr. Desatel, our collaborator from radiology, marked these as suspicious regions in the prior mammograms based on reports that indicated where breast cancer was detected in the patient, not in the screening program, but somewhere else. Unfortunately, we could not get the mammograms on which cancer was detected, but instead, we got only the reports, and these regions were marked as suspicious regions. And in these suspicious regions, we could see, when we got the Gabor filter outputs, that there are structures intersecting at various angles. So we analyzed these images. So you see fibroglandular tissue oriented at various angles. This is the Gabor output and Gabor angle, and it confirms that even in prior mammograms, in the region where cancer was detected later, 1 or 2 years later, there is something suspicious. And we use the same method, getting the orientation field and node map by phase portrait analysis gave a high response in this region. Unfortunately, there are many other regions in the image also, even normal regions where sometimes there could be some intersecting structures and they come out with a high phase portrait analysis response in the node map. So we went back and analyzed the false positives. This is a false positive detection. And we took the orientation angle and created a histogram. The histogram of the orientation angles in a small window around the node map, node point detected, had a narrow distribution. Whereas in the case of architectural distortion, the angle histogram showed a broad distribution. That is, there are tissues here with different angles spanning a broader range of angles than in this case. So we computed measures from these angular dispersion, and the angle dispersion is low in the case of false positives, high in the case of true positive. So we analyzed mammograms like this. We said, okay, let's get the phase, the Gabor magnitude and angle, do phase portrait analysis, get the node map, and break the image into parts that are suspicious, up to 30 parts marked like this for the nodes. These pink asterisk points are the node peaks. So let's detect all the nodes up to 30 and then compute more features. The first one was marked here, which is not the suspicious region. The suspicious region is this red square marked by the radiologist. And that in that region, we got 3 ranked number 5, 8, and 15. But after we computed all the additional features like angular dispersion and many others, we were able to reject many of the others, and these are the top 6. And the top one, number 1, is correct inside the box marked by the radiologist. So by computing more attributes and using pattern classification algorithms, we were able to detect suspicious regions that were related to architectural distortion, that were in regions where cancer was detected much later. So we made the claim that our methods can detect early signs of breast cancer 15 months ahead of time on the average over a number of patients, with a sensitivity of 80% and fewer than 4 false positives per patient. And at the time of this publication, 80% sensitivity and 4 false positives per patient was the performance in the detection of very clear masses and tumors. So this work by one of my PhD students was substantial and significant and won an award from the Medical Research Council in Canada. So these are some examples. Let us see, can we perform CAD, and what do we need to perform CAD? We need to do objective analysis of medical images for computer-aided diagnosis. We need to enhance image quality, detect subtle signs of disease, do quantitative analysis of diagnostic features. Objective aids to diagnostic decision must be developed through pattern recognition, pattern classification algorithms. And we want to get accurate, consistent, and reproducible analysis. And such work can lead to earlier detection of breast cancer and reduce morbidity and mortality, as we have shown. But why do we want to do CAD? Manual analysis of medical images, even by expert, is susceptible to intra-observer errors or inconsistencies, and inter-observer errors and inconsistencies, and limitations of manual analysis. Intra-observer errors or mistakes by the same person are due to inconsistent application of knowledge by the same person, due to subjective and qualitative nature of the analysis performed by visual inspection, due to environmental effects and distraction, and fatigue due to workload and repetitive tasks. When you have to work with 100 cases of mammograms in 2 hours or 3 hours, it's easy to get tired and miss some details and cases. Inter-observer between radiologists or between medical specialists, between people, are due to inconsistencies in knowledge and training. One person went to this school, another went to another school. One passed with so many marks, another passed with higher marks. One has a better understanding, the other doesn't. Differences in opinion and preferences, and also due to subjective and qualitative analysis. Limitations of manual analysis, inconsistencies in identifying landmarks, errors in landmark locations, extensive time and effort required for manual marking and measurement, limitations in the precision and reproducibility of manual measurements, and subjective and qualitative nature. I keep bringing this because that, I believe, is at the core of the problem. And we want to get away from subjective and qualitative analysis and move to objective and quantitative analysis. CAD, our application of engineering techniques, can give consistent application of established rules and methods, objective and quantitative analysis, numerical precision, accuracy, and speed of computation, ease of repeatability and reproducibility, and immunity to effects of work environment, fatigue, and boredom. The computer doesn't get tired. So the CAD way to improve medical diagnosis is to move from qualitative analysis to quantitative analysis. And how do you do that? Via computation of measures, features, attributes, using image processing and signal processing techniques. We want to move from subjective to objective analysis by development of rules for diagnostic decision-making using pattern classification, machine learning techniques. We want to move from inconsistent to consistent analysis by implementing established rules and robust procedures as computational algorithms. And we want to remove inter-observer and intra-observer errors and improve diagnostic accuracy through what we have talked about today: medical image analysis, medical image informatics, and CAD. So what are the main steps of CAD? Pre-processing to remove noise and artifacts, detection and segmentation of regions of interest, extraction of features, measures, attributes for quantitative analysis, selection of the best features. You may compute 100 features, but how many do you really need? Which perform well and which don't perform well? Which combination of features will give you the best performance? So there are methods for feature selection. Then training of classifiers and development of decision rules. For this, you need a data set that is annotated, marked by a radiologist or cardiologist. And then pattern classification and diagnostic decision making. When you have these methods, you need to show how they work. You need to give some measures of performance or accuracy. The typical measures are true positive, false positive. If the test is positive and the disease is actually present as established by a pathologist or medical specialist, then it is true positive. Otherwise, it is false. If the test is negative and the disease is absent, it is true negative, correct. Otherwise, it is false negative. And based on these measures, you can get measures of sensitivity, specificity, positive predictive value, negative predictive value, and so on. These are all well defined and known in the literature. So these measures are used to give an assessment of the performance of a method that you propose or develop. So the basic illustration is a truth table or a confusion matrix. What is the actual truth as given by the pathologist or medical expert? And what is the result from your test, positive or negative? If they're both positive, it is true positive. If they're both negative, it is true. Otherwise, false negative or false positive. I'll skip some of these details, and I'm running a little short. Let me move on. One of the methods that's commonly used is receiver operating characteristic. You plot sensitivity versus 1 minus specificity for various thresholds. Most of your decision-making procedures will have a threshold, and you slide the threshold over the complete range applicable. and get a number of points of performance, different values of sensitivity and specificity. The ideal operating point is here in the unit square, 1, 1. That is, you want sensitivity equal to 1 and specificity equal to 1. You want to detect all cases of cancer, and you also want to detect all normal cases correctly. But that's difficult. If you are here, sensitivity is 0, specificity is 1. You declare everybody to be normal. Just say, you're normal, go home. That doesn't work. If the patient has a disease, it gets worse. The other opposite situation is here. Sensitivity equal to 1, specificity is 0. That is, you declare everyone to be abnormal. Everybody, every patient who comes, you say, you have cancer. Go and get more tests done. So you're catching every case of cancer, but specificity is 0. That is, all normal cells are also being sent for tests. And that is not good. So you have to be somewhere in between. The best point is here, but that's not possible to achieve in practice. So somewhere here, one has to work with a high sensitivity and a high specificity. In our case with the ROP, using tortuosity, we were able to get area under the ROC curve of 0.98 by using the full image. If you are working like this blue curve, the area under the curve, the maximum is 1. We got 0.98, which is very good. If you are detecting tumors and masses and so on, then you have to get what is called the free response receiver operating characteristic, where you plot sensitivity versus false positives per patient. How many false marks did you put? Say, here's a tumor, here's a tumor, here's a tumor. If you say, if you put 100 marks, you may catch the tumor, but there are 99 marks that are wrong. So you want to get high sensitivity. You want to catch all the tumors without putting too many false marks. And depending on the threshold, you get a contour like that. In the case of detection of architectural distortion in prior mammograms, we got 80% sensitivity at 5.3 false positives per patient in this study. In other studies, we got better than that. There are limitations of CAD. Nothing is perfect. Nobody is perfect. Not the radiologist, not the pathologist. No human being is perfect. And no computer algorithm will be perfect either. What has been shown is that when a radiologist who has area under the ROC curve of, let's say, 0.9 uses a CAD tool, which has also, let's say, area under the ROC curve of 0.9, together, when the radiologist consults the computer method, it has been shown that the area under the ROC curve improves to, let's say, 0.94. Still, it is not 1, it's not 100%, but there is an improvement. So by using objective tools and computational methods, it's been shown that you can get better performance. But there are problems. Difficulty in translating methods of visual analysis into computational procedures. The radiologist comes and tells us, this is what it looks like, this is how I detect it. But how do we turn it into a computational procedure? That's the challenge, and that's what we have done in the examples I have shown you. Difficulty in translating clinical observations into numerical features. The radiologist tells us the malignant tumor is speculated. Now, how do you convert that into a number? We developed what we call a speculation index. We developed a measure that we call fractional concavity, and so on. It takes a lot of work and discussion with the medical specialist. Difficulty in dealing with large numbers of features in a classification rule called curse of dimensionality. So you need to develop a feature selection technique. You need to develop first efficient features and then select the best combination. Substantial requirements of computational resources. But that is just money. You spend more money, you can buy a fast computer. And annotated clinical databases. That is difficult. You need large databases of cases marked by clinical specialists, images where blood vessels are marked, tumors are marked with high accuracy. Large number of false alarms and false positives. Increased recall rate, the patients are sent for more tests and more imaging procedures, and that costs money, and that causes anxiety to the patient. That's one of the limitations. Difficulty in integrating CAD systems into established clinical workflows and protocols. Radiologists and medical specialists are used to a certain procedure. They have been working with a certain protocol. Now we go and say, please use this computer, use my program, and put that into your practice. And they have to change their setup, not just the physical setup of putting your computer there, but the whole protocol of analysis of the images and decision-making needs to be modified. There are many popular themes and techniques. We started with image processing and pattern classification, but then the names changed: machine learning, medical informatics, radiomics, and ICT and IT, they are old. Now it is big data and convolutional neural networks, artificial or computational intelligence, and so on. This keeps changing. I know the title of your workshop is Artificial Intelligence AI, but I'm not a fan of that title, artificial. Everything that is made by human beings, everything is artificial. This pen is an artificial writing device. The computer is artificial. This phone is artificial. We don't call this phone as artificial talking device. So why do you want to call this as artificial? Instead, I believe it is a natural process of collaborative working, and this field involves collaboration. But we are engineers. I suppose most of you are engineers. So what are the essentials of engineering that we are bringing here? Scientific investigation and analysis, quantitative and objective analysis. I keep stressing that. Mathematical modeling, design of components, systems, processes, design, modeling. Synthesis, putting them all together. Project management, how do you work through a whole project and develop something? Solutions to practical problems with innovation and creativity. Biomedical engineering is multidisciplinary, and it has evolved. Engineering has moved and expanded application from building bridges to implanting artificial ligaments. Ligaments are bridges of some kind. Electrical power plants to cardiac pacemakers. Cardiac pacemakers power up the heart. Railway engines to prosthetic limbs. Chemical and petroleum plants to artificial tissues and organs. Computers to lab on a chip, and control systems to manage diabetes and other diseases. Communication and control systems to CAD. We need a broad background: physics, chemistry, math, statistics, biochemistry, material science, biology, anatomy, physiology, pathology, sensors, instrumentations, engineering, medical diagnosis and therapy, information processing. It's very difficult for one person to be an expert in all of these. So instead, it is better to collaborate, work as a team with multiple experts from multiple domains. And the subject areas that contribute to computer-aided diagnosis are also fairly wide. Biomedical engineering and medical physics, diagnostic medical imaging, radiology, digital signal image processing, biomedical signal image analysis, that's what I do. Statistical analysis and pattern recognition, computer vision, computers and software engineering, ICT, control systems and decision making. But why call it artificial intelligence? I would rather stay with the term computer-aided diagnosis. Computer, we are using computers for diagnosis, but the computer is an aid. It is a tool that is used for this purpose. CAD incorporates, encodes, and encapsulates the knowledge, intelligence, and expertise of several professionals from multiple disciplines: radiology, diagnostic medical imaging, cardiology, engineering, computer science, physics, math, and so on. And I would like to call this natural human collaborative endeavor. And personally, I feel the label artificial could distract one from this application. It is not that we want to displace or take away radiologists and cardiologists and put computers in their place. I don't think anybody, any of us, would like a diagnosis to be given by a computer when there is a life and death matter. Instead, we would like a human being who is an expert to deal with the problem and treat us properly. So this is not the question of replacing a medical expert, but instead working in collaboration with medical experts and experts from all these domains that I have talked about. So we should recognize, admire, and respect the contributing professionals and their subject areas. But CAD is not the end. Beyond diagnosis, there is therapy, surgery, analysis of response to therapy, prognosis, risk assessment, patient management, clinical management, treatment protocol, and what is now called personalized medicine. I want something very specific to handle my problem and my situation. I don't want a textbook procedure to be applied to me. So all of this requires a lot of work to be done by the medical experts, and computers could assist in all of these. Computational procedures, modeling, and signal and image processing and such techniques could assist, but only assist and not take over. And to assist in this process, there are many procedures and standards being created. There's computer-aided diagnosis, surgery, content-based retrieval, hospital information system, radiology information system, picture archival and communication systems, DICOM, digital imaging and communications in medicine standard, database management systems. All of these are old. Now we have electronic health record, HL7, health level 7 standard under ISO, International Standards Organization, and Open Systems Interconnection. All of these will assist in what is called IHE, integrating the healthcare enterprise, how to put all of these techniques we are talking about into the hospital and make it work with the medical experts. So for that, we certainly need collaboration. So there are opportunities for us, scientists and engineers, to learn new areas of application of engineering in medicine and biology, collaborate, that is, work with professionals in other fields of research and investigation, not go threatening to replace them, but work with them, contribute to another field with significant applications and benefit to the public in terms of health, develop multidisciplinary perspectives and problem-solving skills on our side, and contribute to the well-being of people. So the question now arises, do you believe in CAD? I hope my seminar has given some motivation and some example to illustrate what we can do with this in this field of endeavor. And we have worked in this, and we have a few resources available. If you go to my website, you will see some of our books and some of my lecture notes and so on. You're welcome to browse and collect some of the material if it helps in your study and research. My email is there, and that's my website if you wish to go and visit. I thank the funding agencies that supported my research and my students and collaborators. So I thank you for your attention. This is like an overview or a tutorial kind of a talk. I haven't gone into the specific details of any one particular application. Instead, I have tried to show you a number of different applications, a number of different approaches and ideas, and hopefully some of them will help you in your work. And I hope you enjoy and take benefit from the rest of the program in this FDP. I thank Dr. Mehdi for organizing this and also for inviting me. Thank you. Namaskar. If you have any questions, we'll try. Dr. Mehdi, do we have time for questions? How do you want to handle it?
Yes, sir, definitely, sir.
Okay.
Participants, you may ask your questions, please.
Can
Dr.
I
Mehdi,
speak?
there is a question. You want to handle it?
Yeah. Am I audible?
Yes, you're audible.
Yes. Myself, Mehdi from Department of Science. So I just have a query regarding like made that process
I'm sorry. I'm sorry. Your speech
to
is breaking up.
come out with a
I cannot understand you because your speech is getting cut.
that process, the image that we have to bring out a model. Just I want to know that if say we have images from esophageal cancer endoscopy cases in which they detect the cancer through the endoscope. So in that case, how many images should be processed from the different stages of the disease to come out with the definite model? If there is any minimum or maximum minimum number that we have to do, or any statistically we have to come out with some figure?
Yes, I cannot give you a number directly. If you were to consult a biostatistician should be able to give you a number depending on the number of types of diseases you want to detect. That is the number of categories or classes, and the desired accuracy. Do you want 80% accuracy, 90% accuracy, and what is the standard deviation that you will allow? A biostatistician will answer that question. I cannot answer that question. So you have to prepare how many classes are there of the diseases. Well, one, of course, is normal, and esophageal cancer, stage 1, 2, 3, 4, type 1, 2, 3, 4, 5. So you have to make a list. And then you also have to say, well, I would like to achieve 90% accuracy with a deviation of plus minus 5%. Then a biostatistician can answer that question and come up with a number.
Thank you, sir. Thank you.
You're welcome. I saw some text questions flash by.
Yes, sir.
Was there any? Is there any AI models available to detect the spine cervical detection? Could you explain what is spine cervical detection, please? You mean to detect the spine, or? To detect the spine. Well, yes, as I showed, it is possible to detect the spine by eliminating a number of structures, by detecting the bony structures, the hard tissue, by thresholding the CT image. The spinal canal and the vertebral column, rather, and the ribs and most of the large bones have Hounsfield unit values that are well beyond 500 Hounsfield units in an adult. And then you can detect the spinal column or the vertebral column. And what I showed today was how to detect the spinal canal, the actual spine inside the vertebral column. So that is what I showed today. We were interested not only in detecting the vertebral column or the spinal column, including the bone structure, which we did. I illustrated that in the 3D image, but also inside that, the spine, which is within the circular region, but that is only in the thoracic cavity. In the literature, I'm sure there are other methods, but I can't discuss the other methods right now. We have referenced them in our papers on detection of the spine and landmarking. Are there any other questions, Dr. Mehdi?
Subhash da, কিবা question আছে নেকি?
নাই নাই একো নাই
Sir, one more question is there. Is there any data set for mammogram to detect breast cancer? Standard database.
Standard database. There were a few that we used, but they're all out of date now. I have not worked on mammograms for more than 10 years. So I don't know if any new databases have been created. I'm sorry. But if you were to refer to the proceedings of the International Workshop on Digital Mammography, what was called IWDM, you may be able to find. We worked with the MAIS database and the database from Florida, DDSM, but those databases are many, many years old and they are outdated. They are based on film that was scanned. Digital mammograms, I'm pretty sure there are some, but I have not worked on this problem recently. So you'll have to search the literature yourself, I'm sorry. Retinopathy of prematurity can be diagnosed by CAD before birth. I don't think so. I mean, retinopathy of prematurity, as the name implies, is a disease that appears when the baby is born premature. So this cannot be done prior, and we need to detect retinal blood vessels in images of the fundus of the retina. So I don't think such kind of imaging can be done prior to birth. But if there are other markers, of the disease, then that is a different study that needs to be explored.
Sir, I have a question.
Yeah.
Sir, actually, I have heard, I'm not sure, that few people used to say that there is effect of COVID-19 on retina. But I also work in retina, but I don't understand means whether it is correct or not. Is there any effect on the retina?
I haven't heard of any such reports. COVID is affecting mainly the respiratory system.
Yes, sir.
So I don't think it would affect the retina. So most of the diagnostic procedures are based on imaging of the lungs and testing for the virus itself in nasal samples or from the throat samples. So I haven't heard of any report on the effects of COVID on the retina. No.
Yeah, okay, sir. Actually, that was also I have also thought that how can it be affecting retina? It's still hard in some newspapers, so that is why I thought
Uh-huh.
if you may have some idea or knowledge on that, information on that.
Okay.
So one more question is there. Difference between ERG and ENG.
Uh, ERG, you mean from the retina? ENG is the neurogram. I'm not sure what the ERG is. Is that from the retina?
Shankar, is it
electrode,
ERG or EEG?
the EMG is the electroneurogram that is obtained from the nervous system, and that can be obtained from a nerve accessible from the outside in any part of the body. For example, to study conduction in the arm, conduction velocity of the nerve, you can apply a stimulus to the thumb or somewhere here. And if the nerve is stimulated and you get a twitch response, then you know there is a response. And you can measure the conduction velocity, and that is an electroneurogram. What you are measuring is the ENG related to the median nerve here. So that is the ENG. Oh, you are talking about other. Okay. Electronystagmogram and electroretinogram. No, I'm sorry, I am not familiar with those signals. I have not worked with those signals, so I cannot tell you much about that. As I mentioned at the beginning, more and more signals are being accessed and recorded, and one needs to understand the signals through a medical expert in the area in order to extract appropriate features and process them appropriately.
Sir, one question is there any biomedical device for patients suffering with DMD?
And could you tell me what is DMD, please?
David, sir, what is DMD?
Muscular dystrophy. I'm not familiar with muscular dystrophy as such, but with the EMG, by studying the electromyogram, it is possible to diagnose neuromuscular diseases, either neural diseases that are related to the nervous system, connected to the muscles, the stimulation part of it, or the muscle system, the myopathic diseases that affect the muscle cells and muscle fibers. So through EMG, electromyography, and analyzing the signals of the related muscles, it should be possible. I have not worked on that. I have studied some works on the analysis of the EMG signal, and it is possible to diagnose various types of neuropathic and myopathic diseases that affect various musculoskeletal systems using the EMG. There's a question about CAD to differentiate between COVID pneumonia and normal pneumonia. Any specific marker? I'm sorry, I don't know that. It's CAD is, COVID is such a new situation. There's quite a lot of active research going on, and we need to wait and see how this develops. I don't have any answer to that question. I think diagnosis of COVID is mainly done by identifying the virus through its known shape and other characteristics.
Are there any more questions, participants? Okay, I hope there are no further questions. There is one more question: how to predict chronic kidney disease? How can we predict chronic kidney disease?
In one of our works with a pathologist, we had studied the glomerular membrane thickness. And we had studied how the thickness of the glomerular membrane varies with certain diseases that affect the kidney. I'm not sure if that can be used as a diagnostic tool because it requires a biopsy sample and also it requires electron microscopy. So it's invasive and expensive. But by studying the structure of the membranes of the tissue of the kidney, by taking samples, biopsy samples, and by studying the detailed structure through electron microscopy, it should be possible to identify various kidney diseases. I cannot tell you how early in terms of if it is chronic. I'm not sure what early diagnosis would mean. But to study the detailed structures, one structure that could be studied is the glomerular membrane and the thickness of that membrane. But as I said, that requires a biopsy sample and electron microscopy.
Okay, sir. I hope there are no further questions. So, thank you, sir. Thank you for joining with us.
You're welcome.
And it was really a privilege to have you here with us. And we have learned a lot. I hope participants have gained much more knowledge from you. And definitely, we would like to get in touch in future also. And whenever we have any option for such platforms, or we have any such platforms, we'll definitely invite you, sir. And we'd like to see you more and more. Thank you, sir.
Thank you.
Thank you from all our team and department, and as a whole from all our Guwahati University. Thank you, sir. Thank you.
You're welcome. And wish you all the best with your program.
Thank you, sir. Thank you very much. So participants, thank you all. Thank you for joining, sir.